Good evening, everybody. Thank you for coming onto this first series, or first of the series of webinar 2025 by the, which is actually organized by the AFRAN Education Committee. So we have two wonderful speakers, senior veterans from the AFRAN, and at the same time we have two great leaders of the Education Committee out here who will moderate the entire session. So introducing today's moderators, we have Dr. Rasha Darwish. She's a trilingual consultant nephrologist at the Karsar Eleni Medical School, Cairo University. She's currently the AFRAN treasurer and PD chair of the committee, the PD committee. He's part of the ISN dialysis working group as deputy chair, ISPD council member for Africa, a nominating committee member, and the ERA Strong Kidney Task Force member. She has a strong passion for education, research, and advocacy, aiming at equity of CKD care in Africa. The second moderator today we have is Dr. Robert Kalasubula. He's a distinguished nephrologist, researcher, and educator, shaping kidney care in Uganda and beyond. He leads the physiology department at Makerere University and holds adjunct positions at Yale, Vermont in the US, McMaster in Canada, and the Charity University. He trained at Makerere, McMaster, Yale, earned a PhD in NCD epidemiology from London School of Hygiene and Tropical Medicine, and became an FRCP in 2023. He's an ISN fellow, a member of the Young Nephrologists 2015 to 2019. He also was part of the first cohort of the ISN Emerging Leaders Program. He has over 130 peer-reviewed publications, including being the lead editor on the ISN Infectious Conference Proceedings that were published in Seminars of Dialysis. A visionary leader, he founded the Uganda Kidney Foundation. He's the current president of the Uganda Society of Health Sciences, spearheaded Uganda's first kidney transplant in 2023, expanded dialysis access nationwide. As AFRAN's Education Director and Deputy Chair Africa, ISN Deputy Chair Africa, he has driven global nephrology initiatives, including ISN AKI tool and KDIGO guidelines. A prolific researcher and editor, he co-chaired the ISN Infectious Conference and coordinated a WCN 2025 theme. His work continues to shape kidney health policy and practice across Africa and globally. So with this, I thank you for the opportunity, and I hand it over to the moderators, Dr. Rasha Darwish and Dr. Robert Kalasubula, to take over the entire meeting. Thank you.
Thank you very much, Dr. Lloyd. It's been a very big pleasure to have the first session from the AFRAN, which has been long overdue. I want to thank the committee for organizing this conference, particularly Dr. Lloyd for his great insight of speakers we are going to be hosting today. We will be having two speakers has been introduced earlier, and I'm going to be introducing our first speaker, and then Professor Darwish will introduce our second speaker, then we'll have questions. So Dr. Muhammad Abed Gawad is a PhD holder. He is from the Nephrology Unit, School of Medicine in Norwegia's University in Giza, Egypt. He's a consultant at Alexandria, Egypt, and the founder and chairman of NephroTube. I'm sure many of you have seen his work, the books he has edited, and the quizzes he keeps sending across. He's also the chair and member of AFRAN Committee, Web and Media, and also is an outstanding member of the Education Committee of the AFRAN, and is actually always very helpful in making sure that we have good illustrations. He's going to be sharing today about gym nephropathy. You are welcome, Dr. Gawad. Please take the floor. Thank you very much.
Thank you, dear Robert, for this great introduction. I'll start by sharing my screen now. Actually, it's really my pleasure and honor to be a speaker in one of the webinars of AFRAN. Actually, we have a lot of AFRAN webinars that had been done before by different AFRAN committees, and the video recordings of all these AFRAN webinars are on the AFRAN YouTube channel. And at the end of my lecture, I will share with you the links for the website and social media accounts of AFRAN. And also, I'm very happy to be a speaker in the first webinar that is carried by the Educational Committee. With my dear Valerie, thank you for the organization, dear Educational Committee. My talk will about gem nephropathy, bodybuilding versus kidney damaging. Actually, I will cover in my talk a review article that we had published in 2019 about gem nephropathy. Gem nephropathy is a term that we introduced about or related to the harmful effect that may be happen by the non-nutritional and nutritional supplements that are widely used by bodybuilders. We all know that there is abuse of multiple of these supplements that may cause kidney injury. So what is safe and what is not regarding these supplements, that's what I will cover in my lecture. My talk outline, I will cover the most important supplements that are taken into the gem. I will cover talking about I will cover anabolic androgenic steroids, creatine monohydrate, vitamins, protein, high protein intake, and energy drinks. I will start by the effect of anabolic androgenic steroids that are commonly used by bodybuilders, especially the experts of them. At the beginning, I want to mention these statistics or registry. It was about the prevalence rate of use of anabolic steroids in different areas of the world. Surprisingly, in Middle East, the use of these anabolic steroids was very high. And in Africa, away from the Middle East, it was also commonly used by bodybuilders. For the effect of the anabolic steroids on the kidney, for sure, they have very bad effect. This was one of the most famous articles published and discussed the effect of anabolic steroid abuse. And as I will show you, that anabolic steroid abuse, nearly in 100% of cases, it developed focal segmental glomerulosclerosis. This is a report for 10 cases, bodybuilders, all of them were on anabolic steroids. As you see here, all of them are on anabolic steroids and testosterone, whatever the dose. And the duration that they had been on anabolic steroid was variable. Here for 8 to 10 years, for 20 years, for a lesser or little years than 8 years. So the duration of exposure to anabolic steroid was different. At the baseline of the study, all of them, although they didn't complain from any complaint, this is just a cross-section we can say, none of these bodybuilders complained of any sign or symptom. Baseline, but the common thing between all of them that they were on anabolic steroid for a long time of period. All of them, their creatinine at baseline was high, variable from 1.3 in one of them and 7.8 in another. The 24-hour urinary protein at the base was also high, variable and ranging from 1.3 up to 23 grams per day. Biopsy were done for the 10 bodybuilders. All of them, or 9 of them mainly, showed focal segmental glomerulosclerosis, and one of them showed glomerulomegaly that may be developed or turned into focal segmental glomerulosclerosis later on. The anabolic steroids were stopped in these 10 bodybuilders. They had been given supportive treatment and steroids for some of them according to the some indications. Follow up after they stopped the anabolic steroids and after they received the treatment, the creatinine improved in all of the patients, and even the follow-up proteinuria improved in all of them. Some of them still nephrotic, but there is improvement in the proteinuria level after stoppage of anabolic steroids. One of these bodybuilders, this is his real photo, he returned to take again anabolic steroids. Here, where the patient stopped the anabolic steroids, there was improvement in the serum creatinine of the patient, and there was improvement in the proteinuria of the patient. The patient started to retake anabolic steroids, and then after retaking the anabolic steroid, the creatinine raised again, and the proteinuria raised again, and the patient reached dialysis. So from this study, there is an evidence that anabolic steroids can cause focal segmental glomerulosclerosis. Can anabolic steroids affect the kidney by another way rather than focal segmental glomerulosclerosis? The answer is yes. This is a case of 41-year-old man that presented to the emergency department by acute onset of jaundice, fatigue, loss of appetite, weight loss, pruritus, clay-colored stool, and dark urine. It seems that it is hepatic affection. 6 weeks before this presentation, the patient started anabolic androgenic steroids for gym supplements, and he took another supplements and protein shakes. The patient was admitted because of this suspected liver disease. At day 9 of admission, renal impairment started to appear after 9 days of admission. This is the patient creatinine at presentation, 1.1. Then on day 9, it is 1.5, and the patient complained of oliguria. The urine analysis of the patient showed, as you see, this pigmented coarse granular cast, and the diagnosis was bile acid nephropathy in a bodybuilder abusing anabolic steroids. So in this case, anabolic steroids caused liver impairment, and the liver impairment itself caused bile acid nephropathy. So anabolic steroids can affect the kidney even by indirect way. And this is a biopsy of the bile deposition in the kidney. The anabolic steroids can affect the kidney by a third way, away from the focal segmental glomerulosclerosis and away from the bile acid nephropathy. The third method is renal artery stenosis. We all know that anabolic steroids are erythrogenic. They increase the erythropoiesis formation, increases the viscosity, increases the sensitivity of endothelin cell receptors, and they can lead to hypercoagulability and renal artery thrombosis. This is a documented case of renal artery thrombosis in a bodybuilder using anabolic steroids. The most important to mention in anabolic steroid that it is not affecting only the kidney. Actually, it has more common side effects away of the kidney, including CNS and psychiatric side effects, skin side effects, increased cardiovascular risk, gynecomastia, as we mentioned, liver damage, and a lot of side effects. And we actually see in the media the bodybuilders who are experts and they are taking a lot of anabolic steroids. They usually die in a young age. As to my knowledge, most of the famous bodybuilders died within their fourth decade, I think. This may be because of these multiple side effects of anabolic steroids away from affecting the kidney. So anabolic steroids can cause focal segmental glomerulosclerosis, bile acid nephropathy, and renal artery thrombosis. So 100% they are harmful, and bodybuilders should avoid them. The second and one of the most commonly used supplement in the gym is creatine monohydrate, and it is common to be used by the expert bodybuilders and the non-experts. It is very common to be used in those who are attending the gymnasium. Is creatine monohydrate safe or not for the kidney? This is one of the studies that were done testing long-term creatine supplementation in individuals who are already consuming a high-protein diet in the gym. There were two groups, a group of them who received creatine monohydrate, 12 persons, and others who received the placebo, about 14 persons. Both of them had high-protein diet. The creatine dose was loading dose 20 grams per day for 5 days, and this is maybe the usual dose, followed by 5 grams as the maintenance throughout the trial. Both of them, as I mentioned, took a high protein diet, 1.2 grams per kilogram per day or more. After follow-up, there were no any differences between the two groups regarding the creatine, those who took creatine or placebo, regarding the serum creatinine and GFR. Creatinine was equivalent in both sides, with no affection of creatinine in the individuals who took creatine. And even the other parameters that are testing the kidney function regarding albuminuria, proteinuria, and other parameters, there was no statistical significant difference between both. So it seems that creatine monohydrate is safe on the kidney. But the question, is creatine monohydrate totally safe on the kidney? Actually, the answer is no, because there is a report that creatine monohydrate may cause acute kidney injury. This is a 32-year-old man. He took creatine monohydrate for 3 weeks by the same dose or even less than the dose that were used in the study I previously mentioned. The patient is now presenting to the emergency department by nausea and weakness. His creatinine now is 4.3 and serum urea is 111. This is the biopsy that was taken from the patient. As you see, there is mononuclear interstitial inflammation, and the patient was diagnosed as creatine monohydrate supplement-induced interstitial nephritis. The patient stopped the creatine monohydrate and they started corticosteroid therapy, and the serum creatinine level decreased to 1.8 milligram per deciliter. So creatine monohydrate is generally safe, but cases of AKI had been reported. And from my experience, I saw a lot of cases in my clinic by creatinine monohydrate-induced acute kidney injury. One of my comments on these patients that most of them have a very little body weight and the body surface area. So maybe the dose of creatine monohydrate must be adjusted according to the body weight. I don't know, because there is a fixed creatine monohydrate dose that all the trainees took it, whatever their body weight or their body surface area. All the patients that I saw diagnosed by acute kidney injury due to creatine monohydrate, all of them had a little body weight and a little body surface area. So it may be that it needs to be adjusted according to body weight. The third important point that is commonly abused by the bodybuilders is vitamins. Actually, they took a lot of vitamins with very high doses. So what is the danger effect of these vitamins on the bodybuilders? This is a case report of 22-year-old man. He presented to the emergency with nausea, vomiting, and upper abdominal pain. The diagnosis was acute pancreatitis and renal failure, secondary to hypercalcemia. This bodybuilder, his history, he was taking monthly intramuscular 50 ml of cholecalciferol. Imagine that in every ml there was 50,000 international unit of cholecalciferol, very high dose. He was taking that to improve muscle gain in the past 2 years. And this explains his hypercalcemia, acute pancreatitis, and renal failure. And in CT, you can see here nephrocalcinosis, and you can see renal stone. And for sure, in the renal biopsy, you can see interstitial calcium deposits, and you can see also some tubular atrophy and interstitial fibrosis. Even so, in this patient, there is nephrocalcinosis secondary to exogenous vitamin D intoxication, which is actually abused by the bodybuilders. In the same patient, CT of his upper arm showed calcification of the deltoid muscle and of many of his muscles secondary to the vitamin D abuse. And one of the most commonly used vitamins by the bodybuilders is the veterinary supplements. They use supplements of the animals. But in the market, there are capsules and tablets for animals that contain a lot of vitamins. So they use it to get a push or a gush of large amount of vitamins. This is a case, or this is a report, I think it was from Brazil. All of these patients, 16 cases, had renal impairment, had hypercalcemia, secondary to intramuscular injection of these veterinary supplements that they were used to increase the muscle gain and weight. So regarding vitamins, is it safe in gym? Hypercalcemia, nephrocalcinosis, and renal stone can happen if there is abuse of these vitamins. Interstitial fibrosis and tubular atrophy also can be caused by calcium deposits. So abuse of vitamins must be not be done by these bodybuilders, and they have to use vitamins within the recommended doses. The next and important point for all those who are going to gymnasium is protein intake. It is well known that high protein intake is one of the trends that is taken, high protein intake by the bodybuilders. I want to highlight first what is the bad effect, theoretical bad effect of high protein intake. High protein intake, whatever the biochemical way, it increases the glucagon, insulin-like growth factor 1, and the kinine in the blood, which will cause afferent arterial vasodilation, and also it increases the activity of renin-angiotensin system, which will cause efferent arterial vasoconstriction. This will increase intraglomerular pressure, filtration, and maybe proteinuria. That's why maybe protein restriction is important in CKD patients because of this bad effect, one of its bad effect. So does this effect can happen in individuals with already normal renal function, bodybuilder with a normal kidney function that is taking high protein intake? Can this happen in this patient? Let's see the studies. Again, I want to continue the bad effect of proteinuria first. So proteinuria, as we know that some of this protein is reabsorbed by the proximal convoluted tubule. If there is a lot of protein lost, a lot of protein in the interstitium, this will cause activation of fibroblasts, collagen and interstitial fibrosis, and finally tubulointerstitial fibrosis. This is the bad effect of protein. Let's see if it can happen in patients with normal kidney function. This is a crossover trial in resistant trained men, 12 healthy resistant trained men. They tested in them the effects of high protein diet. It is a crossover trial. Arm of the study for 8 weeks was on normal protein intake, and the other arm was on high protein intake. And the next 8 weeks, they crossovered, they exchanged the protein diet. At the end of the high protein intake in the high protein period was about 3.3 and in average gram per kilogram per day. These are a very high, by the way, a very high protein intake. The normal protein intake, they mentioned that it was about 2.6 gram per kilogram per day. At the end of the study, there was no evidence that protein intake were harmful. There is no harm from protein intake regarding creatinine and eGFR in the two arms. But we have to mention that this study was for short duration, only 16 weeks. Another study testing high protein diet in athletic individuals, and they showed that it has no also harmful effect. 14 healthy resistant trained persons, also it was a crossover trial, normal protein and high protein in both arms. Then they cross over for 4 months, then cross over again for 2 months and again for 4 months. The high protein intake was actually near the high protein intake in the previous study, 3.3 gram per kilogram per day. The normal protein intake was about 2.5 gram per kilogram per day. At the end of the trial also, there was no any harmful effect for high protein intake. So what should I tell my patient or the one who is asking me regarding protein supplements in the gym? Are they totally safe? Actually, my answer to these individuals is that generally, yes, it is safe, but we don't have a long-term trials. The second point that I tell them that they are not safe for sure if you have kidney disease, and they are generally safe if you have healthy kidney diseases, healthy kidneys, but long-term effect over years is not known. And the third point that I mentioned to these individuals that you have not you must not use high protein intake if you have kidney stone or you have a history of kidney stone, because for sure one of the bad consequences of high protein intake is the formation of renal stones. So to summarize, what is the effect of high protein intake in these individuals? Use is safe in individuals with normal kidney function, but again, we have no long-term trials. There are theoretical risks, as we mentioned, glomerular hyperfiltration and hyperemia, acceleration of CKD, increased proteinuria, and formation of kidney stones. The last point that I will cover in my talk is the effect or the bad effect of energy drinks. We know that energy drinks have a lot of bad effects, especially on the cardiovascular system, but do they have a bad effect on kidneys? There is a case report for a patient who ingested for 2 or 3 weeks about 1 to 2 bottles of Red Bull energy drink. He presented after 3 weeks of daily ingestion of Red Bull to the emergency department by a serum creatinine 5.5. 14 months before his presentation, by this renal impairment, his creatinine was normal. There was no history suggesting any cause of renal impairment in this patient except the newly ingested energy drink. The energy drink intake had been stopped and the patient creatinine improved. And actually, one of my colleagues reported a case, but they didn't publish it. Crescent glomerulonephritis followed a Red Bull ingestion. There was also in this patient no recent intake of anything. All his immunological markers were negative. So in general, is energy drink safe or not? On the kidney, there is no major reports that these energy drinks are harmful, but as I showed you, there are some case reports that they may affect the kidney, but generally they must be avoided because of their very well-known cardiac effect. So in energy drinks, only regarding kidney, cases of AKI had been reported. So my home messages, I think my home messages is enough to be taken from this table. To summarize them rapidly again, anabolic steroids cause focal segmental glomerulosclerosis, bile acid nephropathy, renal artery thrombosis. Creatine monohydrate is generally safe but may cause acute kidney injury. Vitamins abuse may cause hypercalcemia, nephrocalcinosis. Protein is generally safe, but we don't know its long-term effect and should be avoided in patients with chronic kidney disease and renal stones. And finally, energy drinks on the kidney, they are safe. On the heart, they are not safe. In the kidney, acute kidney injury has been reported. I want to finalize my lecture by 3 slides. The first is research recommendations. If anyone is interested to make a research on supplements of the gem on the kidneys, to add for this sector in medicine, you have to take the following points in your considerations. First, you have to make a study on large number of participants because most of the studies I showed you have a limited number of patients, 14 patients, 12 patients, and so on. The second, it's better to make a longer periods of follow-up, not only 16 weeks. It is better to be followed up for months or even years. It's important that administration of one supplement per group to be sure that the effect on the kidney is its effect, and biopsy is mandatory to detect subclinical cases. So this is my research recommendations if you are interested to make a research on this part. I want to invite all of you to visit the website and social media accounts of AFRAN. This is the website. You will find on it all the materials of AFRAN regarding the webinars, the quizzes. We have a lot of quizzes on it. You will find educational material for patients about chronic kidney disease in English, French, Arabic, and Swahili. You can join the Facebook group, follow the Facebook page, and you will find the recordings of all webinars on the YouTube channel. And finally, you can also follow us on Twitter. The final announcement, we are conducting a study about nephrologist burnout in Africa. This is just a survey. I will put now in the chat box the link for the survey in both English and French. So please take from your time only 5 to 10 minutes to fill this survey because we want to get a lot of responses to able to get a very good effective results. I hope that my lecture was clear and fine, and thank you.
Thank you so much, Dr. Gawed, for this very informative talk. I mean, I personally loved how clear it was and concise, and the message was, I think all of us now, we're going to look at athletes in a different way now. We're going to think about, what about your kidneys? So I think the message is that extremes of anything, even good things, can harm us, including the kidney. Thank you so much.
Yes.
Really, thank you. Well, we'll take the questions. I'm sure we're having a lot of questions regarding this very interesting talk after our next speaker finishes her presentation. I am really honored to present, I mean, I'm sure that all of you know her very well. She's very famous globally and in Africa in particular, Prof. Valérie Lequix. She is, I mean, she is lots of very impressive things. First, she obtained her MBBCH from the University of Witwatersrand in South Africa. She trained in internal medicine at the University of Miami and in nephrology at Harvard Medical School. She holds an MSc in public health and a PhD in biomedical ethics. She has participated in multiple countries in both adult and pediatric nephrology, so she is both adult and pediatric nephrologist. Her research activities include the challenges of justice, ethics, and moral distress relating to source allocation and the prevention and management of kidney diseases, and in particular in resource-limited regions. We all know that she is a very active advocate for prevention of non-communicable diseases, especially kidney health, with the goal of supporting equity. I call her always the queen of equity, local expertise, and fair priority setting for quality kidney care in resource-limited settings. She is currently the chair of the Advocacy Working Group at the ISN and a member of the EUDI Working Group and the Ethics Committee of the European Renal Association, the ERA. She is, of course, actively involved in the ISN and ERA Task Force for Renal Disasters. And she is a board member of the International Society for Priorities in Health. Finally, she serves on the Swiss Central Ethics Committee, and she is a consultant in health ethics and governance unit at the WHO. I don't think we could have found anyone more qualified to talk about ethics, in particular in research, than Dr. Valerie. And I am honored to introduce her because she's going to talk now about ethics in research, which is very important for us researchers to be following her guidelines. Dr. Valerie.
Thank you very much, Rasha. This is a bit embarrassing. I've just looked at the list of all the participants, and there are very much more accomplished people than me on this email. I just want to correct one thing, is that Ifeoma Ulasi is now the chair of the ISN Advocacy Working Group. I passed on the baton to her very capable hands, and she will be taking it forward. So thank you very much for this opportunity. Over the next about 30 minutes, then we'll just discuss a little bit about the review of research ethics. I don't have any financial disclosures. As you heard, I'm sort of involved in a couple of different ethical committees, and as well as working quite a lot on research ethics and specifically implementation research ethics with the World Health Organization, which has kind of brought me to this idea of, trying to understand really how do we improve things. So what I'd like to briefly discuss is the importance of research ethics per se, then some principles of research ethics, and think about ethical questions that might be relevant to different types of studies. And then here and there, I'll just give you some examples sort of from the kidney world. So to start with, if one wants to do research, and we just heard this beautiful presentation by Dr. Gawad, which is fantastic, and we can see, a lot of these are really sort of just collections of cases, and he was making a plea that I think we need to understand this a little better. So if one wants to justify research, research essentially should have social value, but it should also have scientific value. And then on the other side, the researchers also have various responsibilities. And the first is obviously to respect participants' rights and welfare, but also researchers who do research must make sure that they are well trained. And then when one does research, especially if the question has social and scientific value, which it should have, there should be an obligation to disseminate the research findings and be accountable to the public in whom the study was actually done. So most researchers kind of look up at the ceiling and roll their eyes when they think they need to go through an ethics committee. And unfortunately, it's true that some ethics committees are quite slow and some might be a little bit difficult. But the bottom line is, I think, and this is what I've really learned at the WHO, the ethics committee is actually there to help you to do your best study. So they're not there to try to stop you. They're actually there to try to support you. And the whole process of developing a research protocol, obviously one has a draft and one plans the study, which we'll discuss in a little while. Generally, before an ethics review, there should be a scientific review because the ethics reviewers are not necessarily technical experts in the field of the study. And then the protocol should undergo ethics review, and then one gives feedback to the actual researchers, and they should then optimize their protocol. So this whole thing is really, ethics is not just a checklist, because a lot of times people just check everything off, and then even from the ethics committee side, one wonders sometimes, did they just say they will do it, but are they actually going to do what we're suggesting is the ethical thing to do? So you have to remember that a study that's conducted ethically is a study that's conducted well. So this is the ethics committee. Ethics and science are all partners here. So why do we need ethics review, though? Because I think all of us as scientists think, well, I'm actually doing it correctly and I'm doing it ethically. But what we know in the history, and a lot of the examples come from the Nazis having done experiments with no consent on Jewish people, Or in North America, there was the Tuskegee study done on Black men in the South, and they just allowed them to have syphilis untreated and kept following them over decades to see what's the natural history of syphilis when they were actually treating the white people. Or, for example, in homes in the United States where children who were disabled were actively given hepatitis to try to see what happens. So basically, these things have happened across the world, and we've known there's also been various studies that have been published and studies done without ethics. So unfortunately, we need ethics review to try to make sure that research participants are protected. We also need to make sure that ethics complies with international ethics review compliant requirements. And what is adding complexity now is previously one used to do a study in one's own hospital and one's own IRB, into the study review board or the research ethics committee would review the study, and everybody would know the context, everyone would understand the research question, everyone would know sort of the research population. But now more and more, there are actually multi-center studies being done in many different countries. And so here the advice is really that there should be one central ethics committee like the WHO or the major university, but there should always also be local ethics committees reviewing the protocol in the local context to make very sure that the ethics committees that are outside have not missed certain very relevant ethics problems in the local setting. So it needs to really reflect the highest ethical standards. And so in 1979, after all those examples that I mentioned, the Belmont report really came up with what we know now as the basic fundamentals of research ethics. So the first thing is really respect for persons. One way in which we manifest this is making sure we respect patients' or participants' autonomy and inform them and get consent, as well as protecting subjects. So making sure they're not harmed, but also protecting those who are most vulnerable from either being over-researched or from being exploited. And then there's this issue of beneficence and not doing harm and maximizing benefits. So whatever the intervention is, there should really be a ratio that favors benefit over harm. And then there always needs to be consideration of justice, which means distribution of risks, so not overly putting certain populations at risk, not overly distributing benefits to other populations. So this also all comes down to this idea of good clinical practice. And I'm sure many of you who do clinical research have had to get one of these certificates either online or through some sort of a course. And this is really what's required so that things go through this institutional review board or ethics committee. And it's also required that the investigators and the sponsors are, comply with ethics requirements. There's the clinical trial protocol, and then the investigators need to ensure that they do correct monitoring, etc., and they keep documentation. You need to keep documentation of your ethics review, and you need to keep documentation of everything that's going on through the study. So now let's think about how do we actually plan a study keeping ethics in mind? Because if you think about ethics from the beginning, you will much more likely to have a smooth run through the ethics committee. So one of the big questions in terms of ethics and justification of a study is this question of equipoise. So equipoise really means, is there true uncertainty about the effectiveness of an intervention? So if we already know that something works in a certain population under certain conditions, there's no justification to restudy that. But if, for example, we have an old antihypertensive or ACE inhibitors and we want to test SGLT2 inhibitors where they've never been tested before, this is enough to say we don't know the effect of the SGLT2 and it justifies the study. So now, just to briefly go forwards, I'll give you an example of this equipoise in a minute, but just to discuss all the key ethical considerations in research. So the first is really balancing risks and benefits. So in all studies, one needs to think who stands to benefit and who is at risk. And especially in implementation research studies, sometimes, for example, one wants to reduce the amount of sepsis after a cesarean section, one might actually do an intervention on the theater staff to make sure that they're washing their hands and be very clean, but the outcome might actually be measured in the patient. So here, the beneficiary might be the patient, but the people at risk, for example, who are being maybe then judged as not washing their hands properly are potentially the theater staff. So one needs to really think, how does one balance the risk and benefits? In a typical randomized control trial, the actual person who's taking the new medication or taking the new vaccine themselves may be the beneficiaries if the intervention turns out to be positive, but they also are experiencing risk. And so one has to really think here, is there a balance between risks and benefits in a study? So one shouldn't really, the typical example people give is you don't need to do a study to test that a parachute, if you jump out of a plane, is going to save your life. And then one needs to uphold participant autonomy. This is very critical. And here we need to obtain informed consent from anyone who's participating. We'll discuss a little bit later some nuances here, but basically consent needs to be objective, clear, and understandable. You need to identify who should give consent. Is it the patient? Is it their guardian, etc.? In some situations, which we may discuss if we have a bit of time, we need to ask, is consent actually necessary, feasible, and meaningful? And then we need to think about the levels of research participants. As I said, if you're testing something on the nurses and you're doing outcomes in patients, you really need to get consent from both. Then we need to think about justice, as we mentioned, and this means fairness in participant selection. So very often researchers will say, I've only got a small budget, I can only include people who live near the hospital. But the bottom line is maybe people in the rural areas might also benefit from whatever it is that you want to test. And so justice really demands that all those people are also given an opportunity to participate. You shouldn't just do convenience all the time. In some cases, convenience is reasonable, but in many studies, like testing a new therapy or a new vaccine, you should really offer this potential benefit to everybody who could benefit. And a lot of this is also depends on the value of the research question, which we'll discuss as well. And then other issues, as we said, the research should be ethically and socially justifiable. So in theory, you should only really, and especially in low resource settings where resource infrastructure and financing is limited, and often it's clinicians who are really using their own time to do research, you need to be careful that whatever study you're doing is really responsive to local issues and will answer a problem for that local community. If you're going to test something new, you want to make sure that this is going to be sustainable. If it works, it's something that can be carried forward. Again, in settings where research is done, especially where health systems are weak, one needs to think about standard of care and ancillary care, and ideally also empowering patients in terms of patient engagement. So we will discuss all of this in a little bit more. So as we said, we want to make sure the study is scientifically sound, because it's not worth doing a study, because if the science is not good, the results will not be good. So one has to ask oneself, should the study be done? Are there necessary resources available? Is the study actually doable, affordable? Is there a proof of concept that says the study is worth doing in the situation? Is the clinical problem to be tested really a priority locally? You need to think about your study design. Do you need a randomized control trial, a case control trial? Can you do it retrospectively, etc.? And then we'll come back to this issue of equipoise. So this is an example of a study that was done in Switzerland a couple of years ago, where they wanted to test if you can improve transplant function by giving sodium bicarbonate to transplant recipients who have a metabolic acidosis. We've known for many years, this is a little bit controversial, but it seems that giving sodium bicarbonate probably does at least improve nutrition in people with chronic kidney disease and may delay progression. We don't really know about this in transplant. So the question is that even though we often extrapolate things from CKD, strictly speaking, we didn't know if there was a value here in transplant. So in theory, you could say, yes, there was maybe equipoise because nobody had ever done this study before. The problem is that these researchers then came up with quite slow recruitment, because the doctors were hesitant to put randomized patients, when all of us kind of felt, well, the patient might do better on bicarb, and bicarb basically doesn't harm anything. So then they started thinking about, should we actually enroll people on bicarb, stop the bicarb, wash it out, and then re-randomize. So some people will and some people won't get bicarb. And in this case, one has to ask oneself, does the equipoise actually change? There's no hard and fast answer here, but the study was actually done. It was basically conducted for 2 years with a very large budget. And the question that I think a research ethics committee should ask is, if you think about progression of kidney disease or transplant function, how likely are you to see a very huge change in a relatively small number of patients over 2 years? So the bottom line is that the study basically didn't conclude much. They felt there was possibly no benefit, but they felt we need longer studies. So the question is, should all this money really have been spent, knowing that the study would stop after 2 years? And these are questions that I think the ethics committee and the scientific committee should actually come up with and say, if you're going to do this, you need at least a 5 or a 10-year follow-up to really know what you're doing, or a very large sample. So I'm not saying the study was done unethically, but I just use it as an example because I think the idea was good, but unfortunately it didn't deliver what it should have for all the resources. So now if we discuss potential risks, as we said, sometimes the same individual is taking a medicine, may get a benefit, and he himself is exposed to risk, but other times you're doing an intervention on one group and you're going to look at outcomes in the other. So you need to understand what is the risk to the individual participant. You have to think about the whole study. you have to think, are there also social and financial harms? Because, for example, this happened a lot in trying to enroll people in HIV studies, that people suddenly started to get to know that on a Tuesday, there's the follow-up of the HIV study, and then they sort of knew that everybody who went into that building probably had HIV. So this is not a good thing, and this is a risk you have to think about in your study and think how you can mitigate that in the planning stage, and don't wait until you're doing your study to suddenly realize that people are stigmatized. You need to think about risks to groups and populations, and we'll have an example of that a little bit later, because sometimes, for example, there might be vulnerable populations that can be overexploited. I think some of the research in CKDU tends to be happening more and more and more in the same populations. Is this possibly a risk to those populations? One needs to be careful to avoid unnecessary interventions, unnecessary data collection. One shouldn't collect data just because I can. You need to make very sure that whatever you collect is something that you're going to use. The question is to identify people who might be harmed and potentially exclude those. And then, as we said, if you're doing research at a health systems or a health institution level, there is always risk of potential harm to the actual institution. And then in terms of monitoring of risk, this is something important that the ethics committee will insist. There has to be a data safety monitoring board. If you're doing an intervention study, you have to define what are stop criteria, when are things actually not safe to continue, and then we need safeguards. The researchers need to plan how to mitigate harm. So research risks are along a spectrum, and sometimes the research might be actually reviewed on an expedited way, or it might even be waived. So you might even get an exemption for ethics if the research committee thinks that there's minimal risk. And minimal risk means that serious harm is very unlikely and uncommon. This is usually associated with retrospective anonymized data, or, for example, sometimes anonymous surveys are considered minimal risk, because as long as you explain in the survey, if you don't know who, you can't identify who the participant is, then that's something that often ethics committees will consider relatively low risk. And here's an example of a retrospective study that was done in Burkina Faso in 2010. They looked at all their AKI patients between 2004 2006. So here they were just doing a retrospective review of charts. They were not doing any intervention, not putting any new patients at risk. But in theory, unless they, when they collected the data from these charts, unless they really de-identified and anonymized the data, if their database in an Excel sheet or something got into the wrong hands, they might then have seen patients' names, patients' birth dates, etc. So there is always this risk of still violating privacy and confidentiality. So this is often something the ethics committee will ask you to be very clear. Where are you saving the records? Under lock and key? Who has access to this? Is this in a password protected computer, etc., etc. So here the risk is minimal, but you still have to always think about privacy and confidentiality. In another study here, this is from the Sudan, where they actually, and this is an example of what I'm meaning, they looked at adherence of healthcare professionals to evidence-based clinical practice guidelines in the management of hemodialysis patients. So this went through the ethics committee, and the ethics committee said that this was fine. And again, every time you write a study, you need to include a sentence saying that it's gone through ethics committee, and be ready to produce the documentation if someone asks for it. But interestingly, they say here they got consent from all. So the question here is they were looking at whether the healthcare professionals are adhering to guidelines. So were they actually looking at the doctors, or were they trying to see if the doctors did the right thing, if the patient's outcomes would be better? So here you would think to yourself, who are actually the participants? Are they the patients? Are they the doctors? Are they both? And then you have to ask yourself, which outcomes are they going to measure? So as we said, either patient outcomes, or are they going to check that, the clinicians all ordered erythropoietin as they should have, et cetera, et cetera. So one of the big risks here is if you're doing this over a region, let's say, and you've got various different hospitals, and then in your research, you say hospital 1, hospital 2, hospital 3, and it turns out hospital 3, no doctors were actually following guidelines, and maybe patient outcomes were bad. The question is, if people can actually identify this hospital from your research somehow, that could actually cause significant reputational harm to this hospital. So this is also something that you have to think about. You may not have anticipated in the planning of your study, but you have to think that these are possible eventualities. And so the researchers have to be very, very careful that they don't make anything identifiable. So this really means that you have to think about non-obvious risks and benefits. We've just discussed this one of reputational risk, but there are a lot of other non-obvious harms, and sometimes these are related to culture, religion, gender, whether people are allowed by their family members, whether they can give consent, etc., whether people even think about including them in studies. But pregnancy, for example, is something very specific. And my experience at the WHO is that we had an urgent appeal to include pregnant women in the Ebola vaccine trials, because traditionally, and the companies were saying we cannot vaccinate pregnant women because we don't know the risk for the fetus. But ultimately, a pregnant woman who got Ebola had a 90% risk of dying. So ultimately, the ethics committee said, no, you have to include pregnant women, or at least inform them and give them the option to accept the vaccine. So this was interesting because traditionally we try patronizingly to protect pregnant women, protect children, and exclude them from studies. And we know, for example, with the SGLT2 inhibitors, the children have been excluded from studies. And this is really leading now to a big delay in our knowledge in the use of these drugs for children. So it's important to think about these harms, but sometimes there might actually be undue benefits. And here, for example, if you want to do a study to try to improve patients coming to clinic for follow-up, some studies have tried to give taxi vouchers so that people actually come. They don't have this big expense. But if you think about it, the taxi industry might then become very destabilized. And this actually happened with antenatal clinic visits in a clinic in Nepal, where the taxi prices then suddenly started to rise, and the taxis were only interested in taking the women to clinic, and there weren't taxis available for others. So you must think to yourself that there could be undue benefits, and a certain other totally unexpected group that has nothing to do with your study might actually benefit. And so you need to think about this as your researcher when you're planning your study. And the way you can identify these potential benefits is through appropriate community and stakeholder engagement. So stakeholder engagement, and I'm sure a lot of you are much more familiar with this than me, but it has multiple components, and this is really showing respect to the community. And in theory, if your research is to be socially responsive, this means that ideally you're going to be answering a question that's important for that community on the ground. So this would be called ground up research. What's the ideal is if a community comes to an academic institution and says, we have this problem, can you help us to try to figure it out? So that would be ideal. Very often there are foreign universities, foreign investigators who are suddenly interested in some disease somewhere like malaria or HIV, and you have these foreign people coming in to actually do their study in an environment that they're not familiar with, like let's say in Africa or India or somewhere. So then ideally, the foreign researchers can't just go and work on malaria because it happens to be common in a certain area. They need to make sure, is malaria important for this community? And is this community actually going to be on board with the study? So even right at the beginning of drafting the study, there should be community engagement, but one needs to decide, how do you do this? Do the white researchers from North America come to some little village in Kenya and start speaking to the community, or do they go first through the chief or the local head person or the local administrators and say, could we please speak to your community? Can we identify someone who can help us to speak to the community? So there's a lot of different ways one must do this, and one has to do this as respectfully as possible. One has to think, when do you do it? Definitely you should do it before the study, but ideally also throughout. You need to think about where, ideally also locally in people's environments. What are you going to discuss with the community? How are you going to discuss this with the community? And who can help you to actually make sure that you're engaging properly with this community? So all of these are actually ethical obligations for researchers. It's no more acceptable that helicopter researchers can come and study things where they just feel like it's convenient. So a great example of this community engagement is this study called the MyTemp study that was done in Canada, where they looked at personalized cool dialysate for patients trying to reduce episodes of hypotension on dialysis. Study was published in The Lancet, was massively funded, was a huge cluster randomized trial, meaning that various dialysis units were randomized rather than individual patients. The whole set of patients in one dialysis unit was randomized either to a lower or a higher dialysate temp or a normal dialysate temperature. And interestingly, the study went on for 4 years and they didn't find any benefit. But what was really fascinating is when you read the paper, they put in their discussion that they anticipated that this personalized approach to dialysate cooling would be better tolerated. But when they did a survey after the study, the respondents said they were freezing the whole time, and actually there were not even enough blankets in the dialysis units. But I think anyone who's put a foot in a dialysis unit knows that the person who's under the air conditioner or near the window is always freezing. So I really don't think that this should have been a surprise to the investigators. And this is one of the problems. Sometimes these big research groups are more researchers than clinicians. But here, if they had spoken to the dialysis patients in the first place, the dialysis patients may have said, no, we don't want to because we hate being cold on dialysis, or make sure we have enough blankets. So this is a very good example for me of the need for this community engagement. Another big question that often comes up when research is done in low and middle income settings is this idea of incentives. And these are not generally acceptable because, especially when the research participants are poor, even a soap or a packet of sugar can be something that's coercive, meaning it's forcing the patient to participate in a study that they would not otherwise want to participate in. What's important here with the incentives, though, is that this should not be confused with essential reimbursement of direct costs like transport or loss of earnings, etc. So here again, one needs to be very transparent in one's research protocol going through the ethics committee, and one has to really think about the potential impact of incentives. What is quite interesting, though, is that there's now this new field of research called controlled human infection studies. And they're doing this with malaria, where healthy people stick their arm in a box that's full of mosquitoes and risk catching malaria. Or in England during COVID, they actually put young people in a room where they knew that there was someone infected with COVID. And basically, these young people agreed to get infected. So this is a whole new kettle of worms for ethics committees, because the huge question is you're putting a very healthy person now at risk of a potentially very severe disease. The question is, who agrees to do this? And if you look in England, the young people who did the COVID study were actually paid more than 4,000 British pounds for their participation, with the risk they would get COVID and could even potentially have landed up in ICU or even died. So the huge question here is, this is a very big ethical minefield, but in some cases it could be scientifically informative. One just wonders who it is who agrees to be paid $4,000 to go and get sick. So it's extremely important that research participants are well informed. And we all think we do this. We think we do this also clinically in the hospital. But this was a very interesting study that looked at multiple surveys that were done in people who had been consented in developed and developing countries. And as we can see here, for example, the understanding of what the process of randomization meant was really broad. A lot of people in developed and developing countries did not understand this. And similarly, very horrifyingly, sometimes only 10 or 26% of people actually even understood what the whole study was about. And yet they've signed the form, or they've put their thumbprint, and they've agreed to go ahead. So we need to be a little bit more rigorous in terms of making sure that we really understand that people have really understood what they're getting into when they signed consent. So there are a lot of barriers. I don't think we have the time to necessarily go into this. I think there's obviously culture, language, stigma, confidentiality, etc. What's very important, we often use words like research, placebo, randomization, maybe genetics, and these terms are not often understandable for patients. We need to think about forms of signature. Sometimes if it's a study on HIV, for example, a patient might not want their name on that form just in case it gets lost. So we have to think maybe a verbal consent is enough. And then we have to think in vulnerable populations like orphans, pregnant women, prisoners, etc. How do we consent these people? So now we come to the actual research conduct. And here again, the ethics committee is going to ask questions about justice. And so as we mentioned already, we need to ensure fairness of participant selection, but we also have to think what actually happens during the study in terms of appropriate standards of care and ancillary care. So sometimes, as we said, people can be over-researched. And so here is an African-American subject saying everyone wants me for research, but nobody wants me as a patient. So that's also not good. We all very embarrassingly realized during COVID that pulse oximeters don't work well enough in Black people. This shows that the wrong people were in these studies from the start. And we know in the kidney world that our patients are very often excluded from studies in cancer, for example. So all of this is not good. These vulnerable populations have been left out. And if we think about dapagliflozin, we all know that none of these studies have been done in Africa, even though everyone's claiming a global effect. So this is also important. So now if we come to standard of care, this means what care should be provided during the study, especially to the control group. So for example, if you're going to study a new antihypertensive, you need to make sure that the control group has consistent access to the same and a good quality antihypertensive. You can't just accept that every week there's a different antihypertensive available in the local hospital pharmacy and that will be good enough. So acceptable standard of care must really be according to the best available evidence. And then it needs to be very careful that researchers don't take advantage of existing poor standards of care. And this was an uproar that happened during COVID, that some French person said, let's test the effectiveness of TB vaccination in COVID in Africa, because they already don't have masks, treatments, or resuscitation, so we'll know very easily if this TB vaccine works. And so, of course, there was a pushback, and this person had to retract this, but this really showed people's mentalities. On the other hand, here's a study from Senegal, and they wanted to test a whole lot of new natural remedies for hypertension. So they had a standard treatment of captopril, and this continued in the control arm. And even if these other concoctions were, or not concoctions, these traditional remedies were not working, they even made sure that the people in the actual active arm got the right treatment. So this would be correct, appropriate standard of care. And you have to think, if research is happening in a poor resourced environment or weak health system, there's a lot of needs that might actually come up. And this brings up this term of therapeutic misconception, where patients might sometimes enroll in a study because they think it's healthcare. But even if patients do understand that it's research and not healthcare, they might still get sick during a study. You need to think, when the person comes for their clinic visit and suddenly their sugar is very high, their blood pressure is very high, what are you going to do about that? Sometimes if you do a home visit, you might actually see that someone else in the house is sick. What are you going to do about that? And so researchers need to plan ethically, because they do have a responsibility, because they're coming across these problems. They need to think about appropriate referrals, or are they themselves going to deal with the problem? Usually this is not possible for the researchers. And then very critically, if an intervention is successful, there has to be post-trial access to this intervention affordably and sustainably in this community. Otherwise, there's no ethical justification to test that drug or intervention in that community. Capacity building is also critical, as especially lots of big research institutions are doing research now in low and middle income settings. They need to build and leave good research infrastructure behind. They need to train the researchers, develop equal, respectful partnerships. They need to train and empower patients. They need to sometimes also participate in capacity building of the local ethics committee. Ideally, this process of community engagement is going to build trust and understanding in the community for research, which is then specifically helpful in emergencies where one might need the community to understand very rapidly. One needs to also build capacity in terms of publication, distribution of findings, and using the results for advocacy. So this is basically just quickly the obligation. So the point is, you shouldn't do a study if there's not going to be scalability and sustainability afterwards, and there is an obligation to disseminate. As we said, there should be public accountability. Data handling is a big thing in terms of privacy and confidentiality. We won't go through this in big detail, but you all know how to do this. And the biggest thing is also, just when you're ready to publish, don't accept all the invitations from the predatory journals. Just try to get into proper journals where people will actually then take your research seriously. So the further ethics considerations also is that very often the low middle income researchers are kind of left out sometimes of authorship, or stuck in the middle, even if they've done most of the work, and the visiting medical student who's on holiday for a month might actually be the first author because they wrote the paper. So here we need to also push and expect that there is fair acknowledgement of everybody's contributions, respect for intellectual property, and one needs to learn how to discuss these and really speak about it up front. So finally, basically, considerations in research in low resource settings are exactly the same as in high resource settings. The same ethical standards must be upheld, but here there are more important considerations about responsiveness to the health needs of the population. You shouldn't be wasting research money on questions that are not relevant. You need to make sure that there's post-trial availability of effective interventions, build capacity of the locals, and think about all these ancillary and standard of care questions. So finally, ethics is not always black or white. You should work together with the ethics research ethics team, not against them. It should be a constructive process. Think about unanticipated harms in your research. Think about vulnerability. Be transparent, accountable, objective, fair, and then be careful to share your results. So I'll just finish here with this website for the COMS guidelines. This is freely downloadable. It's a whole little PDF textbook, and you can download this, and a lot of all these things that we've discussed today are there that you can look at in more detail. So hopefully this hasn't been too quick. I apologize, but hopefully we can have some discussion. Thank you.
Well, thank you, Valerie, for a very interesting and
Sorry, I'm
stimulating
trying to stop
presentation.
the sharing.
I mean, it was, the stories, it was many stories which were very kind of interesting for all of us. And you open several subjects because we are all researchers at the end and we want to get answers, but at the end, what are we doing in the way and how can we do it right? It's such a big subject, and I'm so happy that you tackle these issues so openly and so frankly, because we need that so that I mean, we are targeting to try to increase the research, especially in Africa, because we need it, and via AFRAN, and that's why we chose this subject as the first webinar. But again, I think we'll need more and more presentations like this one, because this can't be just done by just once. I mean, we need a full course about proper ethics. Really, thank you so much, Valerie. It was a pleasure, as usual, and thank you for your time. Robert, would you like to take over and maybe start seeing the question? Maybe you can start seeing if we have questions and having our beautiful speakers answering them.
Thank you very much, Professor Daoud. I think there were a few questions, largely going to Dr. Gawad. The first one, and by the way, I hope everyone has seen the link to the questionnaire. It's short.
Yes.
I've finished mine, so please fill in yours.
Thank you.
So I think the
Thank you.
first question was about diuretics and can diuretic use in bodybuilders for weight management be a confounder in kidney effect of other supplements? Dr. Gawad.
Yes, for sure, it can be a confounder. Even itself in its own is a risk factor for kidney injury in these patients. Even I discovered, and I don't know if this is a common practice in your different countries or not, that some of the dietitians and nutritionists may use diuretics for their patients to decrease weight. Actually, this is not an actual decreasing in weight, it is just loss of some water, but it is very harmful because they are usually using high doses in a short duration. We saw a lot of cases with hyponatremia second to diuretic use in these individuals who are not actually a patient. So it may be a co-founder with other supplements, and by itself is harmful and may cause kidney injury.
Well, I have a similar question.
Thank you
actually.
very much.
Yes, I mean, Robert, I mean, Dr. Gawad, I've heard that some are actually using insulin as well for weight loss in bodybuilders. Have you seen similar
Yes,
cases? And
yes, I saw, but a few of them are using it because for fear of hypoglycemia, but they may use it as insulin is an anabolic hormone that may increase also the protein in the muscle, but actually very little individuals use it. It is not
okay.
commonly used between bodybuilders.
Wonderful.
Robert,
Thank you very much.
can
So
you read the
what role?
Yeah.
Yes. What role do electrolyte supplements such as potassium, sodium, and magnesium play in kidney health, especially for bodybuilders who train intensely and lose large amounts of sweat?
Okay. Actually, there is no studies on this point exactly, but there is an expert opinion. The excess use of these supplements may be harmful. For example, excess use of sodium may cause hypertension in these individuals, which may affect the kidneys. Increased intake of magnesium may not be excreted by the kidney, causing hypermagnesemia. The suggestion by the expertise in this point mainly is to replace these electrolytes only by normal diet. Actually, the amount of sweating that is lost during bodybuilder training is not that much, even if they are training in a place with air conditioning. So the amount of sweating is not that much that may need replacement, and if it is needed, it is better to be replaced by normal diet rather than these supplements.
Wonderful. Thank you very much. I think Professor Dawad, you can take over the questioning. Dr. Gawad can answer question. How did you rule out primary FSGS in this group of patients to be sure that the chemicals used were the causative agents of FSGS?
Okay, to differentiate if this chemical agent is the causative factor, we have to differentiate in the same way as any focal segmental glomerulosclerosis by the degree of food effacement in electron microscopy. If it is not diffuse, if it is segmental less than or focal less than 80% of the food process effacement, so it is usually secondary cause. So most of these cases have criteria in the electron microscopy of secondary focal segmental glomerulosclerosis. no diffuse food process effects. That's why it is suggested that these focal segmental glomerulosclerotic cases are caused by these abused substances.
I have a similar question actually also. I've also heard about some of the athletes abusing growth hormone. So have you seen cases like that?
There is no study on most available studies on growth hormone use in bodybuilders, but the theoretical rule or the theoretical point in this issue is that growth hormone may cause kidney hyperfiltration also. Okay, that may affect the kidney in the same way as amino acids or high protein intake. So it is not safe at all.
Thank you. Do we have
Can I
Professor?
make a quick question about growth hormone?
Sure, go ahead, Valerie.
We had a young patient who was transplanted and failed 2 transplants, was back on dialysis. He took growth hormone. Someone told him it would bring back his kidneys. And he developed massive hyperparathyroidism and tendon ruptures in bodybuilding. So it's quite interesting. People can get this stuff from anywhere. He bought it on the internet.
Yes.
It's amazing.
And lots of actually trainers in the gyms. I think the major issue is that those who are prescribing these anabolics and growth hormones are not physicians. They are actually trainers in the gym encouraging others to use it. And the fact that they can have access to these and use them is really scary. So I think something should be done about that. I think it's getting more common than we can actually admit. I don't know if you have the same thing in Switzerland, Valerie, but it's getting pretty serious, I think, in our region. How are these things in your
I've actually had some young girls who've had AKI with Red Bull and young men with creatine. So I agree. The stuff is all over the place.
Firstly, congratulations to both speakers. I enjoyed your talks immensely, even though I believe Valerie mistook the time. I think she did very well. The question I wanted to ask was in regards to ethics. You know, one of the things that you have to tell your ethics committee when you apply for permission is what is long-term sustainability. And we're always talking about equity, that we feel that Africa is left out of clinical trials. And we do know that companies will provide the agent, the drug, as long as it's unregistered. But as soon as it's registered, you have to pay for it. And it's really, really not affordable in many instances. So I just wanted some of your thoughts, and maybe even Dr. Gawod's thoughts on how does one address this. And often these are drugs that are life-saving or would make a huge difference to people's lives.
Absolutely. I mean, I think you're 100% spot on. And I think now there's more and more the expectation that the companies have to commit to that. And I think, you know, as a researcher, if you think this is going to be a problem, this should be part of your own stakeholder engagement. You should be engaging with your Ministry of Health and telling the Ministry of Health, this study might be useful, this drug might be a game changer, and how are we going to negotiate with this company before we have any results? Because the minute you start to have positive results, the company has the upper hand. So all of this is critical, you know, at the stakeholder and the engagement and planning stage. And I think this is interesting. I think we now know that Vertex is doing these studies of the APOL1 sort of therapies. And in theory, they've committed to providing sustainable access. I don't know how they're going to do that. But I believe the researchers have a right, and I really feel if you bring on your decision makers who will be the one who will then be paying these bills, because I think it's unrealistic that the drug is for free, but it should be then sold at an affordable price. I think if you get the right people involved right at the beginning, you can negotiate all of these possibilities so that you don't, because otherwise it's just not ethical to do the study. You're just providing data for the company, and then they're just raising prices elsewhere.
The question is, would it not exclude us, especially in Africa, from participating in these trials? Because I do know that Big Pharma is not really anxious to come to the party in many cases.
Well, but I think, you know, Big Pharma needs to be
do have access.
Yeah, sorry. I think Big Pharma should have a responsibility to include everybody. And this is part of this justice in research. You know, you can't just take the convenient people at the Mass General or at Harvard or wherever. You know, you have to also say this drug could, like the SGLT2s, could have game-changing effects, and even bigger game-changing effects in places like Africa, where it'll save lives like directly. you know, because nobody can even get dialysis, or few people. So I think we need to start expecting more from these pharmaceutical companies. Often the researchers are just so grateful to get money and, you know, funding, that they forget that they're the gatekeeper to the study. And so the researchers and the local researchers need to really also make sure that they are standing up for their communities and ensuring that these companies, you know, and I think also need to advocate that we need global inclusion, because I think there is an ethical obligation now for these drugs to be tested on everybody, because we know that then suddenly it works or may have more side effects in different populations. So I think we all need to have a greater expectation.
We need a strategy. Thank you.
Yes. And in those COMS guidelines that I mentioned at the end there, you know, the stakeholder engagement is critical at the beginning. I think somebody has a question here about is it unethical to use renal biopsy specimen that was performed for diagnostic purposes with a consent, but not have a direct benefit for the patient? And I'm sure many of you can answer that. I don't know if Robert or Sarah has an answer for that, because I think, you know, there again, if you want to do a biopsy on a patient and put them at risk of bleeding and the usual things that are risks of a biopsy, it should be something. You shouldn't be just doing it out of curiosity. You know, what do you think? I know H3 Africa did a lot of biopsies. What was your thought?
You don't think the question relates to use of archival material rather than doing a biopsy? Because while I'm very pro biopsy, if I don't see any direct benefit, I think that's really unethical, because while harm in expert hands, the question of injury and loss of kidney is low, but even if it's 0.0001%, for that person it's 100% if they lose a kidney or lose their life from bleeding. So I personally would be very loath to go ahead to the patient.
And I think, for example, if one wanted to do a study on, let's say, atypical HUS, and you want to biopsy people and you find it, but then you can't actually treat it because the eculizumab or something's too expensive, that would also not be justifiable, you know, to put the patient at risk of finding a diagnosis that then you can't treat. So I think all of these things, especially if it's research, if it's clinical, might be sometimes a different story, but if it's research, you know, anything in the study should really be done if that person, especially if it's the same person taking the risk and who can benefit, they have to also, first of all, be informed. I think that's different to these young sort of risk-taking people who want to get malaria or COVID. But this is very, very different. And I think it's not ethical to biopsy and make a diagnosis if you can't do anything, just to say, oh, we want to find the prevalence in this place. You know, if it's a prevalence from a blood test is one thing, but a prevalence from a kidney biopsy would be something that's not ethical if you can't treat. Sometimes the prevalence is necessary, like they used to test people for hepatitis B before they had treatment, or hepatitis C before they had treatment, to show where the hotspots were, so that then those, you know, later on when treatment became available, they knew where to focus them. But that was really a blood test, which is a minimal risk, you know. Was I think the idea of using archival tissue, if the biopsy's already been processed by the pathology and you have your diagnosis clinically, and there is a bit of tissue left over, some patients, when they sign consent for biopsy, do also sign and say you can use leftover tissue for studies, and that's, you know, generally okay, if that tissue is not still necessary for that own patient's care, but it should go through an ethics committee.
Thank you so much,
Yes.
Robert. I think there's a question for also Gawad regarding, shall I read it for you, Gawad? I mean,
yes, which one?
someone asking about how is it ethical that someone is taking supplements which were supposed to be taken by animals, and that humans to buy them. So how can they even get access to that? Do you have any information? Speaking
Yes,
about
it is very easy to get these supplements. There is no regulation for selling these supplements. So by money you can get anything. But actually it is totally non-ethical, because the dose of vitamins and supplements in these drugs is supposed to be taken by animals. So it is not ethical at all to take or to sell these supplements. How to regulate that? This is a governmental issue. It is very difficult to be regulated by societies or scientific societies. It is a governmental issue that must be regulated by a law.
I wonder who thought about this the first time to take an animal sacrifice for human. It's really
It is very common, by the way, very common.
it's crazy. Robert?
Yes, thank you. I don't think I see more questions, and I think our speakers have done a very good job, and I think Val really answered the other question. So the person was talking about leftover. In my country, which is Uganda, if the people did not consent for the use of leftover specimen, then you cannot use it unless you go back and look for the consent. So what the ethics board requires is that if you suspect that you use this specimen, you also consent the person participating for future use of that specimen. But I don't know how the other countries are handling that. But yes, if there was approval and the specimen is left over, then you can use it even if there's no direct benefit to the patient directly. You probably would not even have access to them. I think we have come to the end of our program. I want to thank everyone, first our speakers, for ably talking about these wonderful topics. I want to thank the Education Committee for finally coming up, the AFRAN Education Committee for finally getting us together and getting us these wonderful speakers. And then I see that we have a lot of seniors in attendance. Respect to you, all protocol observed. And then want to thank Lloyd, Dr. Lloyd, who has actually made sure that everything goes smoothly today. So we want to thank you. We want to wish you a happy morning, afternoon, and evening, because we know that this is an international conference. We'll be giving you more of this. So please also feel free to share some of the topics you might be interested in. And if you have key speakers that you might also be interested in, we are with the AFRAN and the ISN, and we can actually almost get any speaker to come and talk to us. So please keep us engaged and follow us on the different medias that we have, outlets. We'll be happy to deal with you again. Thank you very much.